Good morning, everyone. My name is Tahir Musa. I am the Chief Resident for the Internal Medicine Department. And in today's Grandrounds, I will be talking about basics in hypertension management. So I'll kick off this lecture with talking about the blood pressure parameters. Yes, we are starting with the basics, and of course, it's really important, and it has impact on how we manage our patients and how we choose our treatment path for our patient based on their degree of hypertension or where they fall on this spectrum of blood pressure parameters. For the normal blood pressure, patients should have systolic of below 120 and diastolic below 80. For elevated blood pressure, their systolics would fall between the 120, 129 systolics, but they would still stay below 80 of diastolic blood pressure. Now, the hypertension is divided into two stages. Stage 1 with a systolic blood pressure of 130 to 139 and diastolic blood pressure 80 to 89. And stage 2, they would have a systolic above 140 or above, or diastolic of 90 and above. And it would make a difference in terms of how we treat our patients, how intense we start regimens and things like that, and we will talk about this down the road. It's worth to mention in here that if you had a patient that had systolics and diastolics that fall into two different categories in the hypertension stages, then you categorize the patient under the higher stage or the worst stage. And those numbers and categories are based on the 2017 ACC/AHA guidelines for prevention, detection, evaluation, and management of high blood pressure in adults. So why do we care? Simply, when I care, we all care. All right, so why is it called the silent killer? Are we just treating numbers when we treat hypertension? Consequences, what are the consequences of untreated hypertension, and what are the benefits of blood pressure control? These are all questions that we ask ourselves when we treat our patients, or when we try to control their hypertension. Are we just looking at numbers and treating that? And what is the meaning of treating people's blood pressure and getting the numbers down? And that's what we're going to look at in the next few slides. And here I mentioned I wanted to talk about the SPRINT trial, since it looked at a lot of those outcomes in terms of the benefit of treating patients' blood pressure intensely. The SPRINT trial was a trial that was done on over 9,000 patients. Those patients were at high risk of cardiovascular events, but didn't have any diabetes or stroke history. There was the people in the study were divided into two groups. One group with intensive blood pressure control, and the other group with a standard blood pressure control. And then they were compared in terms of multiple outcomes, which we will talk about here. So the primary outcome for the study was to compare the two groups in terms of new onset or first occurrence of myocardial infarction, acute coronary syndrome, stroke, heart failure, or death due to cardiovascular causes. And the results of the study showed that the patients in the intensive blood pressure control group, they had a significant reduction in all those complications in the primary outcome. Some other secondary outcome that there was significant reduction in the intensive treatment group was heart failure, cardiovascular mortality, and all-cause mortality. I took this figure from the SPRINT trial, and I wanted to show it here because it shows really important information when you look at it. The graph on top right here, it talks about, or shows the primary outcome, which, like we said, it was defined as myocardial infarction, first occurrence of myocardial infarction, ACS, stroke, heart failure, or death from cardiovascular causes. And what I wanted to point here is you can see a separation in the two groups, in the intensive treatment group with the orange line and the standard treatment group with the blue line, right around 1 year of time after starting the treatment and getting blood pressure under control. And then for the graph below, it talks about, or shows that the death from any cause. And again, you can notice that the separation in the two groups happened around 2 years from starting the treatment. So again, you see the intensive treatment group with the orange line below, and then the standard treatment group with the blue line. We already talked about that the intensive treatment group has lower risk or lower incidence of those complications of hypertension. And here I just wanted to show the importance of time frame here. And the primary outcome started having a significant difference around 1 year, and here death from any cause started having a significant difference around 2 years. And that's why we call hypertension the silent killer, because it's not gonna, the hypertension is not gonna, people having hypertension, they're not gonna have problems right away. They're not gonna have problems after 5 days and 2 weeks and 3 weeks of having high blood pressure. But they're gonna have problems down the road, and we know that from this study. So this is really important for us as physicians to understand the meaning behind treating hypertension for our patients, because we're not just treating numbers. We're not just making the numbers look okay to relieve our anxiety. We are trying to get the numbers down, because with getting the numbers down, we are saving lives 1 year or 2 years down the road, or saving our patients a lot of complications. And I think our patients deserve to understand this idea too, because hypertension is not an easy disease to treat, since patients are asymptomatic most of the time and they don't have any problems, they don't have pain, they don't have any complaints. So it's hard for them to understand why they are taking medicine for their blood pressure. And this is probably something that they should understand, what could happen down the road, which probably could help us with improving their compliance with medications. All right. What I wanted to mention about the SPRINT trial as well, because a lot of people discuss, oh, what if my patients have adverse events and problems due to that tight control of blood pressure? Well, this could happen. The reported significant adverse events in the intensive blood pressure control group were non-orthostatic hypertension, electrolyte abnormalities with very low or high sodium or low potassium. AKI was also another significant adverse event that happened due to intense blood pressure control. And other not significant adverse events that happened similarly in both groups were falls with injury, orthostatic hypertension, or bradycardia. And what I wanted to stress about this point is, yes, there could be adverse events that happens with the intense blood pressure control for our patients, but it's just like any other thing that we do for our patients to help them. That we always outweigh the benefit versus the risk, and this is another issue that we have to outweigh the benefit against the risk here. And when we do that, I think the benefits that we talked about and what we could save our patients from those complications that we talked about in here probably outweigh the risk of the possible adverse events. But no matter what, I think we should always closely monitor our patients until we get them to a safe haven, and then from there we can loosely continue monitoring, of course. And also another subset of people, there is, and we will talk about this later, the elderly people. Sometimes we should consider how tight our blood pressure control based on their function status and things like that. But sometimes there is a case-by-case outweighing benefits against risk, and that's what we do every day. This is another beautiful diagram here that I took from the ACC guidelines, from the 2017 ACC guidelines. And what I wanted to stress about here in this diagram is two things. First, the non-pharmacological therapy, which is something we do for people with elevated blood pressure or for people with stage 1 hypertension, but in the lower risk group. However, if you notice, non-pharmacological therapy is really important along the entire, all 4 groups here. And then even in people with normal blood pressure, we should still talk to them about non-pharmacological therapies such as weight loss, physical activity, healthy diet, even if they don't have hypertension, because we should all do that, healthy and not healthy people. Another point I wanted to stress out here is sometimes we question how fast or how soon should I see my patient after I do any intervention, and the recommendations here are clear for you. If you are doing non-pharmacological therapy for any of those 2 groups, then you can follow your patient in 3 to 6 months. But once you start your patient on medication, you probably should follow them every month until you get them to a steady state and they're doing fine in terms of blood pressure control and not having any lab abnormalities. They're not having any intolerance to the medications or any issues like that. All right, so for the non-pharmacological therapy, like I said, there's a lot of things that we could do. And like I mentioned, it's not only for those people with elevated blood pressure or stage 1 hypertension, lower risk, but it's also important for everybody with hypertension and probably even healthy people. Weight loss is one thing that we could help our patients with. Healthy diet. Reduced sodium intake, increased potassium intake, physical activity, and moderation in alcohol intake. And I'll go over each one of these in the next few slides, and I will briefly touch on each point of these to help us as physicians at least start the right thing for our patients and maybe follow with more intense treatments on those with some other specialists. So for weight loss, and what's the best goal that we can have for our patients when we recommend they should lose weight is they should go back to their ideal body weight, which is based on their BMI. But every kilogram they lose has an impact on their blood pressure, and the impact is a reduction of 1 millimeter mercury in systolic blood pressure for every 1 kilogram reduction in body weight. And the potential impact on their systolic blood pressure could be up to 5 millimeter mercury in the hypertensive patients. And it would be less than that in people with normal blood pressure if they try to lose weight. This is a very important point that we always should talk to our patients about. And if we don't have the skills to give them specifics about how they can lose weight and things like that, then we should probably refer them to dietitians, weight loss programs, but we should get them the resources they need to lose weight. I can't just tell my patients to, oh, you need to lose weight, but not give them resources to help them start that path. Healthy diet. There's a lot of healthy diets that we can discuss for the heart and for hypertension. But one diet that has the highest impact on reducing blood pressure was a combination diet of DASH diet and low-fat diet, which would be essentially a DASH diet, which we'll talk about now, and then low-fat dairy products and limited intake of saturated and total fats. So what is DASH diet? DASH diet generally is food with lower sodium and higher potassium and magnesium and calcium. And also lots of vegetables, fruits, whole grains, fish, poultry, nuts, and low-fat dairy. Limited red meats, sweets, and sugary drinks. Generally, when I talk to my patients about DASH diet, I just tell them they need to eat more vegetables and fruits. They can eat fish and chicken and less red meat. And of course, limit the sugary drinks as much as they can. But you should always give them resources or send them to a dietitian that could help them with more specifics, how to set their meals on DASH diet, or actually a combination diet, DASH diet with low-fat dairy diet, and so that we can get to our goal. And the potential impact on systolic blood pressure with a combination diet is up to 11 millimeter mercury on systolic blood pressure, which is a really big number here that could take your patient down from the elevated blood pressure group down to the normal blood pressure group, or from the stage 1 hypertension down to the elevated or even the normal blood pressure group, especially along with other non-pharmacological therapies that we could do for our patients. And this is generally my diet plan, except that I don't know how to make cupcakes. So, all right, physical activity. There's 3 physical activities that are recommended by the ACC guidelines and AHA guidelines, and those are aerobic exercise, dynamic exercise, and asymptomatic exercise. The one that has the highest impact on systolic blood pressure, and it could reduce it by 5 to 8 millimeter, is the aerobic exercise. I like this one too because there is a variety of exercises that you can recommend to different groups of patients. For example, swimming here, you can recommend it to people that have arthritis problems and issues, and they can't do running on the treadmill or something like that. Cycling is another one you can recommend to this kind of people. Besides that, some people would like one exercise or the other, and that gives them a variety of things to do and still get the amount of exercise they need on weekly basis to have a healthy heart and improve their hypertension. Dynamic exercise is also a good exercise, and it has an impact of 4 millimeter mercury. Asymptomatic exercise, I think it has an impact of 4 to 5 millimeter mercury on systolic blood pressure as well. And all those impacts I'm talking about people with hypertension. If you're recommending those interventions to other healthy patients without hypertension, they still have impact on reducing systolic blood pressure, but it's less so in those people than the impact that we have in hypertensive people. All right, alcohol consumption, it's not just for hypertension, for everything. Moderation in alcohol intake is better for the blood pressure and for any other medical problems. And for men, the maximum drinks they could take daily is 2, and for women is 1. The potential impact on systolic blood pressure is up to 4 millimeter mercury. All right, and don't forget these things, because our patients don't know what they're taking, if what they're taking is affecting their blood pressure, or if what they're drinking or what they're doing on daily basis and their habits and stuff like that could be influencing their blood pressure without them knowing. So we have to do this ourselves. Make sure you review their medication list, and these are just some of the medications that we use commonly and could elevate people's blood pressure. And other things you should pay attention to and you should ask your patients about is alcohol, how much alcohol they're drinking, caffeine, how much caffeine they're drinking. Make sure you ask them about other caffeinated drinks, not just the regular coffee that we all know. NSAIDs, make sure you give your patients some examples about NSAIDs. You'll be surprised with people taking ibuprofen for years and years, 5 and 10, and I had a patient that was taking ibuprofen for 15 years for her arthritis pain, and she never knew. I mean, they never know what the bad influence of those medications on them, and luckily she didn't have any big problems. But always ask your patients about specifics. Decongestants, herbal supplements, illicit drugs, be open and ask them clearly and probably explain that this could affect their treatment and how we approach things. Okay, so we get to the stage 1 hypertension and stage 2 hypertension, and this is where we start thinking about the pharmacological therapy. This is where we start thinking about giving our patients antihypertensive medications. So for stage 1 hypertension, when our patient falls in the category of systolic 130 to 139 with a diastolic of 80 to 89, then the second question would be is asking, do they have any clinical ASCVD, or if they have any estimated more than 10% 10-year risk of ASCVD. And to estimate the risk, it's easy. You pull up your mid-calc and calculate their ASCVD risk and see what the percentage is. When we talk about clinical ASCVD, we essentially talk about we essentially look for any history of stroke, TIA, coronary artery disease with stable angina, acute coronary syndrome, revascularization either of the coronaries or peripheral arteries, peripheral vascular disease, aortic aneurysm. If your patient has any of these, you don't even have to calculate their risk. They already fall in the higher risk group where they should be treated with non-pharmacological interventions and blood pressure lowering medication. And once you get to this point, I can't stress enough, close monitoring. Probably at most 1 month, bring them back and see what they're doing. For stage 2 hypertension people, you treat, you don't have to calculate the risk, you just treat them with non-pharmacological interventions, of course, and then antihypertensive medications. And the recommendation for this group, for stage 2 hypertension people, is to start them on 2 medications from the get-go. Excuse me. So you start those people on 2 medications from the get-go, and that has a significant impact on their health, actually. There was 3 trials that looked at starting combination therapy for this group of people, or starting them on 1 medication, then follow it with addition of a second agent later on. And what they found, the trials were the VALUE trial, the ALL-HAT trial, and the ASCOT BPLA trial. And all those 3 trials, what they saw is the people that were started on a combination therapy from the time of diagnosis and beginning of treatment, they were able to get them under good blood pressure control in a fewer months, way sooner than the other people that were started on 1 medication and then they were they had a second agent added on later on. And what this could do is essentially reducing or minimizing the complications that could happen from hypertension down the road. And if we go back to this graph, when we were talking about how long it takes for us to see a separation in the curve, it could take up to 1 year here for the primary outcome, 2 years here for all-cause mortality. But the point is, if our patients' blood pressure was controlled sooner in just a few months, we could probably save them from getting to this point. I mean, they can have complications any point along the curve, but that's where we see a significant difference in people that have controlled hypertension versus people that don't have as tightly controlled hypertension. And the point here I'm making is that those people that had their blood pressure controlled sooner, we probably saved them getting into those complications, getting into that we should always try to start with, thiazides and thiazide diuretics, and ACE inhibitors, ARBs, calcium channel blockers, which Could be from the dihydropyridines or non-dihydropyridines. Secondary agents are, and these are not all of them, but are loop diuretics, aldosterone antagonists, beta blockers, alpha-1 blockers, direct renin inhibitors, direct vasodilators like hydralazine, central alpha-2 agonists, and the most common one is clonidine. And we are going to talk about the basics for each one of those medications now. All right, so primary antihypertensive agents, and like I said, I'm going to talk about important points and basics in about these medications, and these are information that we should know when we are choosing our medications for our antihypertensive medications for our patients. So we'll start with the thiazide diuretics. The most preferred one is chlorthalidone, but that doesn't mean that this is the most commonly used one. Probably hydrochlorothiazide is more common among us. And chlorthalidone is more preferred because it has a prolonged half-life and it has a proven reduction in coronary vascular disease. Hydrochlorothiazide is a very common one that we use, and there's other ones, indapamide and metolazone. We use them way less often. A very important thing that we should pay attention to when using those medications, we should ask our patient about any gout history. If they have gout and they're already on a medication for gout and it's stable, then you could consider using the thiazide if this is one of the limited options you have left. But you have to monitor them closely, make sure they don't have gout flares. If you can avoid it and you have an alternative, then you should use an alternative, even if they're on a medication and their gout is stable. You should monitor for hyponatremia, hypokalemia, high uric acid, and high calcium. Avoid using thiazides in GFR below 30 because they have lower efficacy when it gets to that point. Second group I'm going to talk about is ACE, ARBs, and direct renin inhibitors. I know direct renin inhibitor is not a primary agent, but I put it here just because it falls in the same group. It works, it functions similarly, and it has similar points that we have to pay attention to and make sure we don't fall on those problems. We should not use any of these three medications in combination, not just the ACE and ARBs and direct renin inhibitor, because using them in combination would increase the risk of side effects and actually has no added benefit, but actually it could worsen things and could cause problems. Those medications have the risk of have the potential of increasing the risk of hyperkalemia in patients with CKD, in patients taking potassium supplements or potassium-sparing agents like spironolactone. Any of these agents can cause acute renal failure in patients with severe bilateral renal artery stenosis. Any of these agents should be avoided in pregnancy. ACE inhibitors can cause angioedema, and if they do so, you never give them to the patient again. Now, ARBs, usually in practice, if our patient had angioedema due to ACE inhibitor, then we don't give them ARBs. But per the ACC recommendation that you could still use an ARB, but you should use it 6 weeks after the discontinuation of ACE inhibitor in those patients that had a history of angioedema. But even if you use it, you have to be very careful. You have to monitor your patient very, very closely because angioedema could still happen with ARBs. Like I said, again, usually in practice we don't do this. We just, if our patient had angioedema to ACE inhibitor, then we just don't use ACE or ARBs either. Calcium channel blockers, and they're divided into two groups. The dihydropyridine group includes amlodipine, felodipine, nifedipine, nicardipine. These medications, we should try to avoid them in patients with heart failure with reduced ejection fraction. But if we needed to use any of them, then we probably should choose the amlodipine or felodipine. These agents are associated with pedal edema, more common in women than men, and it could be less intense if we use this agent along with ACE inhibitor. Non-dihydropyridine calcium channel blockers. Examples are diltiazem and verapamil. Those are medications that you should not use. You definitely should not use in patients with heart failure with reduced ejection fraction, and that's because they worsen the cardiac function. And you should avoid combining them with beta blockers because they increase the risk of bradycardia and AV block. Okay, we go to secondary agents next. And we'll talk about diuretics first. I'm going to talk about two types of those diuretics, the loop diuretics and the aldosterone antagonists. And in this group, in the loop diuretics, there is furosemide, torsemide, bumetanide that we can use, we're all familiar with. Usually we use them in patients with heart failure, with symptomatic heart failure to try to reduce the volume overload. They're also used as an antihypertensive medication, and if the patient's GFR is below 30 and we shouldn't be using thiazide anymore, there could be an alternative to thiazides in this case. Aldosterone antagonists, eplerenone and spironolactone, they are actually recommended to be added as the fourth agent in patients with resistant hypertension who are already on 3 agents. One of them is a diuretic. We should avoid using them in significant renal dysfunction. Avoid using them in patients taking potassium supplements or potassium-sparing agents. The spironolactone has higher risk than eplerenone in causing gynecomastia and impotence, and eplerenone could require taking twice-a-day dosing, which could have some issues with compliance with patients. All right, beta blockers. There's a lot of beta blockers that we could talk about, but I'm just going to mention a few that we use more commonly, or we use them for a specific indication. For example, the metoprolol, saxonate, the bisoprolol, the carvedilol. They are preferred agents in patients with heart failure with reduced ejection fraction. Carvedilol is a medicine we should remember because it doesn't only have beta blocking effect, but it also has alpha blocking effect. So it has stronger effect on blood pressure. And we could use it sometimes to our advantage when our patient is already taking a beta blocker and we still need more, we still have more room on blood pressure control and we need to control their blood pressure more intensely. Then we could switch their whatever beta blocker they're on besides carvedilol to carvedilol, and that would give us improvement in blood pressure control, and at the same time we wouldn't be adding an extra medicine, so probably we could help our patient with compliance and reduce polypharmacy. One small tip I could give about carvedilol is when you're changing between metoprolol to carvedilol, it's a 4-to-1 ratio. If your patient is on 100 metoprolol total daily dose, then they should be on a total daily dose of 25 milligram of carvedilol, which would be 12.5 BID. For beta blockers, definitely avoid abrupt cessation because that could cause reflex tachycardia and problems. And avoid using non-selective beta blockers in patients with reactive airway disease. If you don't know what non-selective beta blockers, just search them quickly and make sure you know what beta blocker your patient is on. Atenolol is a beta blocker that we see commonly used for hypertension and other indications if our patient has heart disease or something like that. And it's not really an appropriate medicine to use in this group. It showed that it was less effective than placebo in reducing cardiovascular events. So when when you see a patient with a 10LO, you should probably try, especially if they're on it for hypertension, you should probably try to switch into another beta blocker that has better outcomes, better studied outcomes. Alpha-1 blockers, doxazosin, prazosin, and terazosin, these are agents that could be used as a second-line agent in people that have benign prostatic hyperplasia, or BPH. Any of these agents could cause orthostatic hypertension, especially in elderly people, so use them carefully. Direct vasodilators, we talked about hydralazine, or mentioned hydralazine, and also minoxidil. When you're using hydralazine, make sure you pay attention to the side effects that it could cause, which are water retention and reflex tachycardia, and that's why you could probably use it with the diuretic and beta blocker to have a good effect and not have too much side effects. Remember that it's associated with drug-induced lupus. Hydralazine is a TID medicine, 3 times a day medicine, so your patients could have issues with compliance and taking this medication regularly every day. It's not an easy medicine to take. If you needed to use it, then probably make it your 4th or 5th agent to use after you exhausted all the other options and use them, or if you couldn't use some other options for some contraindication, then probably you could use it, but keep it to use in the last resort agents. Minoxidil is another agent that could cause water retention, and you should probably use it with loop diuretic. It's associated with hirsutism. Central alpha-2 agonists, I said the most commonly one that we use among these agents is clonidine, and this is really a last line agent. We see a lot of patients on clonidine, and I would say inappropriately, without even being on any other or being on minimum other antihypertensive agents. They could be on just one agent, and then the second agent would be clonidine, which is completely inappropriate. Some people have been on it for a long time, and we try to get them off of it. Just remember, do not stop those medications cold turkey. Try to wean them down, or do your best in weaning them down. And if you couldn't wean them down completely before they leave the hospital, or when you see them in clinic, just give them a clear plan when they're at home how they're going to wean their clonidine until they see you the next time. I'm going to talk about special populations and how we treat their hypertension in here. I will start with the elderly people, with people 65 years and older. And those people, when we think about them, the most important thing that we think about first is their functional status. If my patient is elderly but their functional status is high, they're living independently, they're doing things, and they're around and about in the community, then I should probably target a low blood pressure of below 130/80. So I should try to get them under intense blood pressure control, and then of course closely monitor for any adverse events. But those patients that have comorbidities, they have limited life expectancy, they have a low functional status, we have concerns about them taking multiple medications, we have concerns about them being able to take their medications appropriately, then we should reconsider how intense we should control their blood pressure. We should have a discussion with our patient about their preference. We should limit their polypharmacy as much as we can, limit the number of antihypertensive medications that we're going to give them to the minimum, but with a good control of their blood pressure. Of course, to the goal that we decide based on what we think about them and how much we can help them. Again, if their life expectancy is very limited, like we said, the complications and consequences of untreated hypertension is not going to happen in the next few days to weeks. It's going to happen in the next few months to years. The African American group. This is a group that we should always remember because we treat them a little bit differently than white people, and that happens when we look at those patients. The first-line agents that we talked about are thiazides, ACE inhibitors, ARBs, or calcium channel blockers. But for African American people, our first line should be thiazides and calcium channel blockers, as long as they don't have CKD or heart failure or diabetes with albuminuria. Now, if our African American patients have chronic kidney disease, heart failure, or diabetes with albuminuria, which is defined as more than urine albumin more than 300 milligram a day, then our first line should become ACE inhibitor or ARB, just like the first line for white people. So they're all part of the primary agents, but it's a preferred agent that we should use for our African American patients. So thiazides and calcium channel blockers. There's a lot of information that recommends that we should treat our African American patients, or usually our African American patients, they need two agents instead of just one agent to control their blood pressure, two agents or even more. For coronary artery disease patients, those patients that have prior myocardial infarction or stable angina, we should have them on goal-directed medical therapy with beta blockers or ACE inhibitors. And actually, this diagram makes it really easy to look at it. Once you have your patients on beta blockers and ACE inhibitors or ARBs, then the second question is, if their blood pressure is controlled and they're doing fine, then you're good. If their blood pressure is still high, then you ask another question, do they have angina or no? If they do have angina, then your third agent after the beta blocker and ACE inhibitor should be a dihydropyridine calcium channel blocker, which would be amlodipine or felodipine or nifedipine. If they do not have any angina, then you could use a calcium channel blocker, you could use a thiazide diuretic, or MRA, or which would be a spironolactone or eplerenone. So if they have angina, start with a calcium channel blocker, and that would target hypertension and target relieving angina symptoms at the same time. Heart failure patients, for people with reduced ejection fraction, again, we should have them on goal-directed medical therapy with beta blocker and ACE inhibitor or ARB. And other agents that we could use for those patients are spironolactone and eplerenone, and that's when it's indicated for severely reduced EF. We can use loop diuretics if they have volume overload and we need a more symptomatic control along with hypertension control. And one important point here to mention again is do not use non-dihydropyridine calcium channel blockers like verapamil and diltiazem with people with reduced ejection fraction, and that's because we could worsen their cardiac function. In our other group with a preserved ejection fraction, there is the first question we ask and we look at when we evaluate our patients is if they're hypervolemic or no. If they're hypervolemic, then we should try to control their hypervolemia that could lead to control of their hypertension. So probably we can use a diuretic first. Now, if they're euvolemic and they are still hypertensive, then we can use an ACE inhibitor or ARB and a beta blocker. Excuse me. Okay, we talk about now the kidney disease group. And for those patients, when we look at them, we we have to know what stage chronic kidney disease they're in, if they're already in stage 3, or if they're in stage 1 or 2 and they have albuminuria. Then our first-line agent for them should be an ACE inhibitor or ARB, and that's because it slows the progression of kidney disease. Now, if we get them on ACE inhibitor right here, and they become intolerant to it because they have cough or some other problems, then we can switch to ARB. Otherwise, if they don't have any issues, then keep them on ACE inhibitor. Now, if they don't have any albuminuria, then you can use any first-line agent you want, any one of the 4 primary agents. If your patient has a kidney transplant, the recommended first-line agent per the ACC guidelines is calcium channel blocker, and that's because it improves GFR and kidney survival. So probably try to avoid ACE or ARB in those subset of patients. For your patients with diabetes, if they don't have albuminuria, then any first-line agent, any primary agent is fine. If they do have albuminuria, then probably we should give them ACE inhibitor or ARB. Combination therapy, just reminders, things to avoid. Avoid combining ACE, ARB, or direct renin inhibitor. If you want to look at the evidence behind that, look at the on-target study. And this study showed that if we combine telmisartan and ramipril, and those are the 2 agents they studied, it actually reduced proteinuria, but it led to worsening in kidney function and also higher rates of hyperkalemia. Also, don't combine beta blockers and non-dihydropyridine calcium channel blockers like verapamil and diltiazem, to the reason I said before, bradycardia and AV block. Just wanted to remind you again of these. A good combination that we can use, and it was studied in the ACCOMPLISH trial, is the ACE inhibitor calcium channel blocker. They studied benazepril and amlodipine versus benazepril and HCTZ. And I just want to point out here that in the study, the 2 groups' blood pressure was comparable and there was no difference in it, no significant difference. However, when we look at the outcomes, the primary outcomes, which they defined as CV mortality, non-fatal MI, non-fatal CVA, unstable angina, then you can see that the separation in the graph started happening around maybe 4 months or 5 months. And the group of the benazepril plus amlodipine has a significant reduction in events compared to the benazepril and HCTZ. So you can consider this in in treating your patients when you don't have any other specific indications for a second agent, and you could just choose any of the agents you have. Then you probably could combine ACE and calcium channel blocker for them instead of combining ACE and HCTZ. The last topic I'm going to talk about is asymptomatic hypertension in the inpatient setting and management of this entity. And this is really a call to think. What I'm going to talk about here is not evidence-based recommended guidelines, but there is studies, retrospective and prospective studies, that show some evidence that help us with management of asymptomatic hypertension. Those studies that I looked at, I made a QR code for them, so you can open up your camera and scan the code and look at those studies at your own time, if you would like. And this is a topic that we did a quality improvement study in my residency program, and it showed us really interesting results. And based on that, we formed a protocol for management of asymptomatic hypertension in the inpatient setting. So asymptomatic hypertension, just quick definition, is it's basically an elevated blood pressure without any end organ damage or symptoms, symptoms such as dyspnea, chest pain, visual changes, confusion or encephalopathy, severe headaches. Those also include patients that fall in the hypertensive urgency range that do not have any symptoms, and they fall in the blood pressure of 180 to 200 over 110 and to 120. Elevated blood pressure in the inpatient setting is very common for various reasons, and it's estimated to be as high as 72%. Now, how do we manage asymptomatic hypertension in the inpatient setting? The first question and the most important thing to figure out first, is it really asymptomatic? Make sure you go check your patient, make sure you know what's going on, make sure you determine already that this is an asymptomatic hypertension before, or asymptomatic elevated blood pressure, before you proceed with managing your patient. Once you determine it's an asymptomatic hypertension, then you should evaluate your patient for any underlying causes that could cause this elevated blood pressure. There's a lot of causes, there's a lot of things that could cause that. I'm just going to name some of them: pain, nausea, anxiety, or agitation. Probably we held their home blood pressure medications, and that's why 2-3 days down the road during their hospitalization, their blood pressure is up. Drug intoxication or withdrawal. New medication that was started in the hospital, or before they were hospitalized, or before they came to see you in clinic, or sorry, we're talking about the inpatient setting, so before they get hospitalized, or they could be volume overloaded. So if there is any of those underlying problems, you should probably try to target the underlying cause instead of just treating the numbers and trying to bring the numbers down and make yourself feel better. If they're having pain, probably you should treat their pain. If they're having any issues with anxiety, there's things that we could do to help them with anxiety. If they're having volume overload, probably diurese them and get rid of some volume, and that would fix your blood pressure numbers. So that's why once you determine they have asymptomatic hypertension, look for underlying problems and fix the problem itself, instead of just putting a Band-Aid on it and just fix the numbers that would make them look pretty, and the next day they would look really bad again. Make sure you always evaluate for end organ damage. Evaluate for things like worsening AKI or a new AKI. These are things that may not be apparent from the beginning. If you have suspicion for it, check the lab, make sure their creatinine is not worsening and you're missing it, because if that's the case, then that makes them fall in the hypertensive emergency state, which they need a completely different treatment and continuous IV drips and things like that. And then after that, I want to urge you to do your best not to do any IV blood pressure lowering medications such as labetalol and hydralazine. And that's because, like we said, they have asymptomatic hypertension. Probably we are trying to target one of the underlying causes here and treat it instead of just treating the numbers. And we don't want to lower their blood pressure too much with IV medications. So if your patient has asymptomatic hypertension, do your best to avoid those unless you have a compelling indication. Let's say you have a patient with stats post hemorrhagic stroke, and you're trying to tightly control their blood pressure in a specific range, and you still don't have the drips on board, and you need to give them a one-time IV medication or 2 times IV medications. That's fine, as long as you have a compelling indication for it. Things that we could do once we figure out all these issues, and if we determine that their blood pressure is elevated and it's not because any of these reasons right here, and we did everything we can and their blood pressure is still elevated, then one thing we could do is review their medications, and if we were holding some of their home medications, please resume that. Even if it's 1 a.m., it doesn't matter, it's okay. You can resume that medicine, and then we can just retime it based on when you gave it. Or during the day, or any time when you're treating your patients. Now, if they are already on a blood pressure regimen, then another thing you could do is titrate up their antihypertensive regimen that they already have. If they are already at optimal doses, or if they are not on any medications, antihypertensive medications at home or even in the hospital, then consider starting a new long-acting oral agent that would be appropriate for them based on their medical issues and things like that. So the bottom point here is treat hypertension, treat this elevated blood pressure in the inpatient setting just like you treat hypertension normally. You have a patient with uncontrolled blood pressure, then probably titrate up their medications, start them on a new appropriate medication. Any of these options is fine. Now, if for any compelling reasons, like if your patient had a history of hemorrhagic stroke or heart failure or coronary artery disease, and you want to lower their numbers quickly, then you could probably consider any of the short-acting oral agents like captopril, Coreg, clonidine, furosemide. The one that has the best evidence is captopril or ACE inhibitor in general, but the captopril is a short-acting one, and it could give you good results quickly, quicker than the other ACE inhibitors. So this is an option that you could use if you really have a reason for it. If not, then you don't have to worry about the numbers themselves as long as you do some action. You treat the underlying cause, or you titrate their medications or start them on a new medicine. And this could be difficult when a nurse calls you at night and they're telling you that their patient's blood pressure is really high and they need something to be done about it. Then and you only say, okay, we're going to treat their pain or we're going to treat their anxiety and not really give them any blood pressure medication, like as needed blood pressure medication. Sometimes this could be difficult, but this is our job, is to educate. So we should educate our nurses with what we know, and that hypertension or elevated blood pressure in those couple hours is not going to be the biggest issue, and we should be treating the patient appropriately. And if they understand this idea, I think they would go along with your plan. Like I said, there is some evidence for the ACE inhibitor to be a better option compared to other agents, and this was based on a study that was done, or a systematic review and meta-analysis done by Souza. You can open your camera and scan this code and look at this study if you would like. Adverse events that are caused by the as-needed IV antihypertensive agents are hypotension, which could lead to dizziness, lightheadedness, syncope, and chest pain. This was a study that this was one of the studies that I looked at. You can scan this code again and look at the study if you would like. Other problems with using as-needed IV antihypertensive agents is it would lead to holding the subsequent oral antihypertensive medications used. We probably all can relate to this. We come in the morning, and we have plans to probably titrate up our patients' blood pressure medications if their blood pressure was still high. And all of a sudden we see their blood pressure is like 100/60 or 90/60, and that's because they 3 to 4 hours ago they got an IV dose of antihypertensive agent, maybe labetalol or hydralazine, and that would mess up our entire plan and could even make us hold their morning dose because of the temporary reduction in their blood pressure. And then in the afternoon, their blood pressure bounces back up, and we don't know what to do. That delays our plans and messes up our timing and things like that. So that's another reason not to do as needed IV antihypertensive patients in the inpatient setting for asymptomatic hypertension. Another thing that was seen in this study, and those 2 points were seen in this study that you can scan its code and look at it also. What we saw also is quick reduction in blood pressure, more than 25% within 6 hours, which we all know that this could be dangerous and could lead to adverse consequences like end-organ hyperperfusion and end-organ damage, and you don't want to do this to your patients. And those 2 reasons, those 2 consequences, could lead to this consequence, which is prolongation in hospitalization. And this was seen by a study done by Dr. Witter. You can look at this, you can scan this code and look at the study yourself. So what we could see is we could cause a lot of problems: hypertension, holding medications, end-organ hyperperfusion and damage, prolonged hospitalizations by giving our patients as-needed IV antihypertensive agents when they did not really need it. They are completely asymptomatic. They have elevated blood pressure. Yes, the numbers are high. We don't like them. They cause us some anxiety, but probably we could hold on, treat the underlying cause, titrate the oral medications up, resume their home medications, or start them on an appropriate new medication, just like we treat any other hypertensive patient, if needed. Like I said, this quality improvement project was done at the University of Kentucky in my residency program, and this is a diagram that we came a chart flow that we came up with, and essentially this is something that you could use. You can take a picture of it and use it if you would like, and this is something that guides you to when you get called from a nurse that your patient's blood pressure is up. What should you do? How should you evaluate the patient? How should you assess them? When should you treat them? I think it's a really cool diagram that you could use for your own benefit. And this is our study that we did. You can scan this QR code and look at it if you would. So again, this is a call to think. I'm not saying this is evidence-based guidelines, but this is something based on observations, retrospective studies, prospective studies that were done by multiple people, and eventually probably we would have a trial that would prove those points and become guidelines or something. But until then, it's really up to you to think about what we discussed here and see if you think you still need to treat your patients with elevated blood pressure in the inpatient setting. And due to the COVID-19 season and no one watching this lecture here in the conference room, if you have any questions for me, you can email me at thayer.musa@erlanger.org, and I'll do my best to answer your questions shortly. These are my resources, and thank you very much for listening today, and stay safe, stay home. Thank you.